to the fourth webinar of the webinar series organized by MENA Society, Neuro, and Global Migraine and Pain Society. It's my pleasure to moderate this meeting with Doğa Vural from Gazi University, and it's our honor to have a guest moderator from Azerbaijan, as well as two valuable speakers this evening. And now I give my word to my colleague, Doğa. Please.
Thank you, Esme. I would like to also welcome you to our fourth MENA GMPS and Neuro webinar. Today we have a guest moderator from Azerbaijan. I would like to introduce Dr. Serkan Amirkuliyev. He's a migraine and headache specialist at Republic Diagnostic Center in Baku, Azerbaijan. He's a co-founder of the Azerbaijan Migraine Specialists Association. He received his master's degree in migraine and headache medicine in Kiel, Germany, and he completed a 2-year fellowship at Danish Headache Center. He's an IHS and EHF member. Serkan, the word is yours.
Thank you so much. Nice to meet you. And first of all, I would like to extend my great gratitude for your inputs in providing the webinar series, which our esteemed colleagues giving lecture and clinical cases and sharing the insights and the strategies to improve patient care. And thank you so much for organizing today's webinar and inviting us and my colleagues to participate and be together with you. It's a great pleasure for us to be part of this great team and this project, and to have the opportunity to contribute to the headache fields. And right now, I would like to introduce my colleagues from Azerbaijan. So Sura Gulieva, she is medical doctor, neurologist, and she graduated residency in Education Service Clinic of Azerbaijan Medical University in Baku. Dr. Sura has clinical interest in epileptology, headaches, autoimmune disorders of central nervous system, and neurogenetic disease. And Dr. Ulviya Gulieva, she is also medical doctor and pediatric neurologist and neuropsychologist, member of International League Against Epilepsy and EPNS. She has 70-year experience in neurology with a focus on epileptology and neurogenetic disease. Our today's topics is migraine and epilepsy. And we would like to start with clinical cases by Sura Gulieva, and then continue giving presentation by Dr. Ulviya Gulieva.
Dear Serkan, thank you very much for a kind introduction. First of all, I would like to say thank a lot for the possibility to share some clinical experience, as well as possibility to have alternative opinion within some difficult clinical cases. It's very important for us. So migraine and epilepsy. For the first glance, two distinct pathology, two distinct disorders. But when we try to go deeper through this topic, we can see some shared pathophysiological background, as well as genetic independences, shared clinical features, and actually same triggers, and even treatment options. And despite the exploring new insight to the relationship between migraine and epilepsy, there is still a lot of cases, clinical cases, when it's really difficult to be sure and to be absolutely sure for correct differentiation. So I would like to start with presenting 3 clinical cases. And so let's start. So our first patient is 7-year-old boy, and he was hospitalized. Our first episode of agitation, change and loss of consciousness, followed by seizures. What was the semiology of that accident? Headache started with headache, then immediately after with vertigo and nausea. Approximately 5 minutes later, with vomiting, and then he started to experience some visual hallucination with psychomotor agitation. He told his mother about the presence of some people at home, and so it was absolutely inadequate state. Then he lost his reactions to visual and audiological stimulus, and the patient was admitted to ER in unconsciousness state. So immediately after first interventions, ER interventions, right side hemiconvulsive seizure started. A little bit later, I will share some videos with you. Regarding neurological assessment, within posictal state, no pyramidal and no meningeal signs were observed. A post-ictal EEG revealed left parietal temporal occipital delta waves. So, first of all, we performed a CT scan and it was negative. Regarding the life anamnesis, our patient is the second child from the second pregnancy. The pregnancy was absolutely normal, with no history of ICU and absolutely normal psychomotor development. So no known chronic diseases excepted frequent headaches since early childhood and episodic brief visual auras. I will add some specific information regarding this type of auras a little bit later. So what about the semiology of frequent headaches? The one type of headaches is migraine headaches. Why we concluded that? Because the headaches started suddenly. The localization, most of all, is in frontal area in both sides. Sometimes it's one side, unilateral, mostly on the left. These headaches increase with time and increase with routine physical activity. Also, he experienced nausea, sometimes vomiting within these episodes, and we can observe that the patient is very weak, fatigued during the episodes, and the duration of episodes approximately 6 hours, 5 hours, sometimes shorter. So sometimes these episodes required analgesic use, and it was absolutely effective every time. And the second type of headache is tension type, probably tension type, because it's not so severe. It's like tension feeling within frontal area, parietal, and occipital area, mild and moderate in intensity. So what about the family anamnesis? The mother has chronic migraine and actually nothing more. Later, we performed brain MRI, and the radiological investigation was negative as well. We prescribed the intraictal EEG, but unfortunately, parents refused from the examination. They thought that this could be stressful for patient to have such a lot instrumental diagnostical examination at the same time. So at that time in Baku, Professor Olivier Dulac visited Baku, and we decided to make an examination with him because he's a top expert of epileptological field. So based on the conclusion of Professor Olivier Dulac, it's not an epilepsy, it's probable consequences of migraine. But 2.5 months later, there was a next hospitalization due to practically similar episode. And I would like to show you that episode. At home, it started again with a short visual aura and an impossibility to see anything. And a couple of seconds later, he was weak and feeling some fear. And after that, the parents observed head deviation to the right and eye deviation to the right. Let's see. We can observe nystagmus right side. It continued approximately 5-10 minutes. And then motor seizures started. Right side hemiclonic seizures. And when he was hospitalized, we can observe even hemifascial twitching and right side clonic movements in his hands and in his leg. Okay. What about future further EEG investigation? We perform interictal EEG, and what we can see here, we see left side occipital spikes on bipolar montage. During non-REM 2 sleep, it was quite frequent. We started with levetiracetam 20 milligram per kilos, and 7 months later, the patient experienced the third episode. 2 days before that episode, he had flu-like symptoms. Maybe it was a trigger point, but nevertheless, his state was changed, in state of consciousness, and he lost his vision. It continued quite a long, up to 45 minutes. I would like to show you the video and give some additional commentary. Sometimes he can ask two simple questions. Sometimes he asks absolutely different things. It's similar like sensory aphasia. Able to speak, but not adequate for the question. I didn't add the last video, but I would like to give a commentary. At the end of this state, he wasn't able to speak. We observed dysertric component as well. So we increased the dosage up to 30 milligram per day, and seeing that no seizures observed. Nevertheless, what we can conclude within this clinical case and which home messages I would like to share with you. It's very important to obtain the detailed clinical and anamnestical information. Sometimes it could be very difficult, especially in pediatric patients. If you remember, earlier I said that I will give additional information regarding his visual auras. Sometimes this patient had episodic, very short, up to 10 seconds, 5 seconds visual aura, but this information was shared several months later. He described his aura as 4 square, which divided on 4 episodes, and he sees some different color in each of them. Sometimes children, they are not so interactive, and it's really very difficult. Migraine with aura can be frequent comorbidity in epileptic patient, because if you remember the life anamnesis, comorbid to his seizures, he had quite frequent, minimum 8 attacks per month. It's very important. Episodes of migraine without aura. Even if we couldn't able to make an ictal EEG, but based on the diagnostic criteria of ICD-3, he's fulfilled that criteria. That's why we think that it's better to have additional treatment with anti-migraine medication. But for this stage, maybe due to some stress, parents are not agree with us because one medication for long term, it's stressful factor for family, and the second one gives additional stress. But nevertheless, interictal EEG can be helpful in many cases when we try to differentiate migraine with aura and occipital lobe epilepsy. Sometimes even very, very experienced people in these fields can make a mistakes. It's real case. Okay, what about the second one? It's about 7 years old girl. She was referred for a routine EEG in our hospital with general complaints of headaches. And what we can see during 1 hour interictal video EEG monitoring, the background is perfect. It's absolutely corresponds to the age. But during wakefulness state, we can see phase reversal on bipolar montage on C3 and P3, so central parietal region, and somehow in left temporal region as well. Again, phase reversal in bipolar montage and common average montage. We can see maximum negativity on C3 and P3. So 6 months later, the patient was referred to additional neurological examination and alternative opinion regarding the treatment, because at that time the child was prescribed by levetiracetam 20 milligrams per kilo, but it seems to be unhelpful. What was the semiology of headaches? Bilateral frontal localization, increase with activity, with physical activity, mild photophobia, sometimes nausea, a duration approximately 4 and 6 hours. Frequency was variable, sometimes very episodic, once in 2-3 months, sometimes quite frequent, 8 or 10 days per month. And usually during these episodes, she became dysphoric, passive, feels fatigue, refusing from food, even from social activity, and even from phones and TV. It's difficult to provide an example of exact trigger factors because actually she has quite active lifestyle, but nevertheless not enough time spending under the open air. Brain MRI was negative. So what about the life anamnesis? She's a third child from the 7th pregnancy because of thrombophilic problems in mother, but with normal delivery, normal development, and no history of any other known chronic diseases. So regarding the family history, older brother has ADHD and mother has episodic migraine. So we put clinical diagnosis of episodic migraine, and we recommended try to managing nutrition, water balance, walks in fresh air, limitation of screen times, magnesium B2 supplements, and symptomatic usage of analgesics. Depends on the situation. And maybe possible preventive treatment we'll discuss further based on the frequency of headaches. So the spikes on EEG were explained as occasional, and levetiracetam was stopped. So, as a conclusion, what is take-home messages for the second clinical case? Not every headache needs EEG investigation, because sometimes hyperdiagnostic approach can lead to misdiagnosis of epilepsy and resulting in unnecessary treatment options being responsible for individual and socioeconomical burden, unfortunately. So, and finally, third case report. From my point of view, it's a difficult case, and we have still a lot of questions, and for us, it's unsolved for now. So we need your help. 4.5 years old boy was referred to a neurological examination after 2 episodes. Okay, what about that? First episode was associated with sudden deterioration of general condition, ataxia, changes in consciousness, and as a result, loss of consciousness. I will comment on a video a little bit later. And the second episode, headache and pain in stomach, sudden weakness, drowsiness, change consciousness with only episodic response, head and eye deviations, hemiconvulsive seizures at the end, and was hospitalized with focal epileptic status. Post-ictal EEG was normal. Regarding the life anamnesis, normal pregnancy, healthy child, normal delivery, normal development. He underwent chickenpox in 1.5 years old without any neurological complications. And the patient was diagnosed with ODD as well. So family history, the mother suffered from chronic migraine and the brother has ADHD and transit motor tics. Okay. Let's see what happened in kindergarten. Our patient is here. He plays, but if we see attentively, it seems he's falling down from the chair, couldn't able to stay, falling down again. Here is our patient. He tried to walk, but it seems he's a tactic. Classmate tried to help, but finally he fall down. Okay, and let's see the video on the right. Here he lost, unfortunately, his consciousness. We can see some active movements, but he's not good. And the teacher still couldn't understand what's happened there. Try to wake him up, but without any specific results. Okay. And what happened during the second episode? The mother tried to ask different questions to check the state of consciousness, as we can see. Try to pay him attention, to attract him. There are some partial reactions, visual reactions, but nevertheless, his eyes still turned on the left. Here, the mother still tried to make some verbal contact. There's no ideation here, but he couldn't answer to the questions. And finally, here, some agitation. And later, when he was hospitalized, later when he was hospitalized, the focal epileptic status started, and it was managed with diazepam in the ER room. So what about interictal EEG? First interictal EEG showed nothing. we covered night sleep as well. The sleep structure is perfect, background is perfect, nothing more. And 2 weeks later, within the last episode, he experienced new episode, which started with headaches, stomach pain, and encephalopathic state, which continues quite long, approximately 35 minutes. Then again, had an eye deviation, hemiconvulsive, hemifacial clonic seizures, so focal epileptic status, and he was hospitalized again. So after second motor seizure, second epileptic status, we started with levetiracetam. We continued to increase the dosage of levetiracetam. Sorry, I didn't tell about that, but levetiracetam was started after the first hospitalization, and after the third one, the dosage was increased. And post-ictal EEG after second epileptic status showed asymmetric right side temporoparietal occipital slowing. But despite that, MRI with epileptic protocol was absolutely negative. Considering family history, because the mother had very, very severe migraine attacks, at the same time, she didn't get any treatment. So, by her own opinion. We performed to make a genetic investigation to exclude familial hemiplegic migraine as well as any other possible focal epilepsies with genetic cause. So we find, unfortunately, only VUS, variants of no significance, but we probably know that SCN9A, a couple of years ago, epileptic genital panel, this mutation was covered by that panel, but a couple of years ago, the top experts excluded because it's not enough scientific information regarding the relationship between this mutation and epilepsy. And only one or two case report from 2024 with METs, microcephaly and epilepsy and diabetes mellitus, nothing more. So actually comprehensive epilepsy panel didn't give us additional information. But what is interesting, dynamic interictal EEG, which made it 6 months later, revealed some small left frontocentral spikes and spike wave complexes. We know that some pediatric population, small pediatric population, can experience interictal EEG abnormalities in central areas, central leads. Based on the information regarding the sensitivity and specificity of EEG investigation, EEG have a sensitivity approximately of 64% and specificity about 22%. It means that not every finding, even epileptic discharges, mean that the patient has some specific epileptic disorder. So no correlation with MRI and no absolutely correlation with the semiology of seizure. So 1 year later, he experienced the third episode of acute headache, nausea, repeating vomiting, and encephalopathy, continued more than 2 hours. He was admitted to the hospital, and we tried to manage it with analgesics and antiemetics, and within this management, he became better and gradually returned to healthy states. Unfortunately, no ictal EEG was able at that time. So the parents refused from the ability to decrease the dosage of levetiracetam and just follow up the patient gradually after stopping anti-seizure medication because they're afraid about future episodes, epileptic status and epileptic seizures. So we have headache falling with focal epileptic status. Maybe, yes, it's ictal headache. Maybe it's migraine attack. We do not know exact for now. because not enough information. But I would like a little bit later, I would like, and I will be to hear alternative opinion, and I would like to hear with anti-seizure medication and just see what's happening, or we should continue with that. So, what is the take-home messages based on this case? Distinguishing migraine and epilepsy can be still highly difficult in some cases, demonstrating the need for further research in this field. And the intersection of migraine and epilepsy probably is not a coincidence, but rather proof of intricate web of human's brain functions. So, as a summary of presented cases, I would like to say that correct differential diagnosis between epilepsy and migraine largely depends on the doctor's experience in both fields, I mean epileptology and migraine, headache science, let's say like that. Not every headache requires EEG investigation. And at the same time, differential diagnosis between migraine with aura and occipital lobe epilepsy should require EEG investigation. Thank you very much for your attention.
Thank you, Sura, for this great talk. Let me start with a question. In children, how can we differentiate migraine aura from epileptic seizures?
Okay, actually, migraine aura, based on the duration, usually more prolonged. And migraine aura usually contain with specific signs, mostly black or white colored. Not every time. Oh, so yes, not every time, but most of all. Sometimes it's variable colored things, but nevertheless, usually it's very long compared to epileptic aura. Epileptic aura could be very variable. It could follow with emotional state, agitation, not only with some specific graphic elements, I mean. And regarding the continuing the duration, most of all epileptic aura is short. But as we can see on presented cases, there are cases when it's not like reported in literature, and it makes the differentiation a little bit difficult, hard. Let's say like that.
Okay. Tuba Cerrahoğlu Şirin has a question. She's an associate professor of neurology at Istanbul Şişli Hamidiye Etfal Research and Training Hospital. Tuba.
Hi, nice documented, documented good sample cases. Thank you, Sakura. It's much more difficult to learn the characteristics of the headache, especially in children. But first of all, the headache character should be evaluated well, because as you mentioned, if there is an EEG abnormality, there is a risk of making a wrong diagnosis of epilepsy in these cases. And you mentioned it too, but it should be emphasized again, I think. We know the migraine and epilepsy have common characteristics. I don't have a question. I just want to mention these characteristics. They are both episodic diseases. They are both have aura, and both epilepsy and migraine aura have the same pathophysiology, cortical spreading depression. So if we have a patient with both migraine and epilepsy, we should choose right drugs, anti-seizure drugs, to such as topramat, valproic acids, and etc. Thank you very much to mention these cases. They're really teach us very much. Thank you.
Thank you too.
We have another question from the audience. Ece Yanık wants to thank you for all of these interesting cases and comprehensive presentation. Her question is regarding the case 3. Was a CSF sample analyzed or screened for autoimmune encephalitis?
We perform, actually, I didn't note it there. We didn't check CSF because the parents refused from it, but we check the serum for NMDA and all the panel. Only serum, only blood, not CSF, unfortunately.
I cannot see any other questions from the audience. I think we can move on with our next speaker, Dr. Ulviya Guliyeva.
Hello, thank you for this kind introduction and having me here. I will do my best to unravel the link between epilepsy and migraine, and to do it in 15 minutes. It's really a difficult task for me, but I will do my best. Could you see my presentation now?
Yes.
Okay. After such a good case presentation by Sughra, I would like again to emphasize some similarity between epilepsy and migraines, and also to mention how sometimes it's difficult to differentiate these two both paroxysmal condition. Is it really difficult, such a difficult as we mentioned during our daily practice? Like nowadays is very frequently seen things. Let's ask ChatGPT how to differentiate migraine attack from the epileptic seizures, and it created such kind of the nice reference chart with the features, clinical features, and the investigation features, where we can see the differences very nicely written between migraine attack and the epileptic seizures. And let's go to another two cases. The first one, this is the 21-year-old woman, and her headache started at 19 years. And she had 3 episodes during a year in November, January, and June, where she started to see colored lights, but it appeared in the one eye, in the left eye. The episode was nocturnal, in the middle of the night sleep, and lasting for 1 hour and a half. And this episode was followed by nausea, dizziness, and nystagmus. After the visual aura ended, a throbbing left-sided headache began, which didn't worsen with physical activity, but she was the noise sensitivity. When the dizziness and nausea resolved first, the headache subsided about 2 hours later. And similar episodic headaches sometimes occur without dizziness. During this episode, she was able to communicate and answer to the questions, and during the whole attack, and her consciousness was preserved. Again, if we go to the our chart with the clinical features, and let's find which kind of the symptoms that we see. Sorry. Okay. So first, regarding the onset, we can call it the gradual onset because first we have some kind of the lights, aura with the lights, then the headache appeared and the dizziness and vertigo. Regarding the aura was gradually increased and was long-lasting. And it was also visual and with the dizziness. Regarding the consciousness was preserved during the whole episodes. Regarding the pain was throbbing, was unilateral, but not worsened by activity. Regarding the post-event stage, she was the sleepiness. She had sleepiness. She experienced some fatigue, and the duration was about 4 hours, sometimes even more. So if we put this kind of the clinical criteria that our patient experienced, it looks like a migraine attacks. Let's go to the episodes. They live in the mountain region, and unfortunately, we was not able to record her event because it happened during the middle of the night, and the first close EEG, the clinic that has EEG, the about 5-6 hours far from them. And you can see here the nystagmus. And during this episode, she experienced very severe dizziness and also nausea. And of course, when we look at that type of the MRI, where we see the one-sided huge cystic lesion, and then actually she has the right-sided hemiparesis also. And EEG was not done during the event, but interictally EEG shown very frequent left-sided occipital parietal posterior temporal spikes. And again, but when we look at the investigation results, like the abnormal EEG, even interictally, and MRI that show the structural abnormalities. And she's now seizure-free, about 2 years on levetiracetam. And again, the treatment response, the positive to anti-epileptic, anti-seizure medication, also shown that this symptomatic focal epilepsy with the focal seizure status epilepticus. Another case, 12 years old boy. The first episode occurred at 8 years of age. Episode usually began with a gradually increasing pulsating headache that worsened with movement and followed by nausea, vomiting. And he became sensitive to light, sound, and this episode could even last 1 till 3 hours, but rarely longer. Flashing-like visual disturbances, then the eye deviation, facial jerks appear during an event, typically at least 1 hour after starting of the headache. The patient remained conscious during the headache, but sometimes became unresponsive, especially during the episode of eye deviation and facial jerks. The frequency of episode decreased after carbamazepine introduction, and brain MRI was normal, EEG interictally was done, and it also was normal. Again, let's check our symptoms, and what we can see. The onset was gradual and duration was about 4 hours. But consciousness was impaired, especially during the ongoing episodes. And but he had some kind of the throbbing, but not often unilateral, but worsened by activity headache. And he had the fatigue after this event. EEG was normal, MRI was normal, and but the patient had a good response to the anti-seizure medication. And regarding the aura was very short, lasting a few minutes with a visual aura. And my advice during the first consultation was to this parent to record the event. And what we have here. This is the first event, first video where the patient continuously complained regarding the headache, very severe headache, and call his mother. And also here you can see the nausea and itching and vomiting. And this lasting for a while, about 1 hour, even longer. And here you can see some eye deviation. And for a while you can see the facial jerks. And our MRI was negative, and our diagnosis was childhood occipital visual epilepsy. He was treated about 2 years with anti-seizure medication, and now he is seizure-free without any medication, about 4 years. And regarding the first overlapping cases, was documented even in the beginning of the 20th century and in the middle of the 90s by Jackson and the Gowers. And why it's so sometimes complicating to differentiate this both condition, because there is some common clinical features. Both occur in episodes with period of normal function in between, and both episodes like an attack with different phases. And also these both conditions shared some the common pathophysiology, like cortical spreading depression, some the common gene variants that cause ion channel dysfunction, some receptors, the activation to glutamate NMDA. And both two conditions had this shared genetic mutation and the positive family history. And there are some the treatment overlapping, like common medication, like anti-seizure medication, like valproic acid, topiramate, and lamotrigine can effectively control the seizure and the migraine, and also normalizing of the lifestyle can improve the condition. And also there is some relationship between these two conditions, because the prevalence of epilepsy among the patient with migraines, according to different studies, is about the markedly higher than the general population. And also the migraine in epilepsy patients seen more often than in general population. I would like to share some the good large cohort studies. The first one, the Atalar group published the patient. It was about 800 patients, and the patient with idiopathic and genetic epilepsies. The more than half of these patients reported having any type of the headache. But the 87% of the patient had interictal headache, and among this group of the patient, about 41% had migraine, and mostly frequent, and they clustered the patient with different type of the genetic and idiopathic epilepsy, and mostly frequent and severe migraine type headache were presented in group with juvenile myoclonic epilepsy. Another cohort prospective incidence study shown that the impact of the headache on the patients with epilepsy was assessed by HIT-6 score. And you can see that about more than 37% of the patients had the highly impacted by the headache. And this group of the patient were chosen with the not so severe and not with the so frequent seizure. And there is no any kind of the seizure impact on their headache, and it was happened interictally. And it was seen frequently in female than in male. So another epidemiology study from the Italian group seen the very large scale of the patient children with a headache, about 1,795 patients. And among these patients, 56 patients, this is about 3 and 2% with idiopathic and the cryptogenic epilepsies. And these patients with the idiopathic epilepsies had 4.5-fold increased risk of developing migraine than tension type of the headache. And they also classified this epilepsy regarding the focal cryptogenic epilepsy, focal idiopathic epilepsy, and idiopathic generalized epilepsies. But there is no any significantly different number of the incidence of the migraine in different group of the epilepsy. Another the cohort study from the Brazil seen the patients try to find the relation between type of epileptic syndromes and type of the headache. They totally recreated 304 patients with epilepsy. And about 66% of patients had headache, and the more 72% and 4 of these patients were females. And you can also see that the migraine frequency of the migraines again was higher than the other type of the headache. Regarding the pathophysiology of the aura of migraine and also some kind of the common pathophysiology between the migraine and epilepsy, was the theory of the cortical spreading depression. The firstly observed in 1945 by the Leo during the Harvard when he studied in Harvard Medical School, and he made some and learned the EEG of the epilepsy on the animal model and anesthetized the rabbits and recording the EEG, and he suddenly suddenly observed the depression on the EEG lasting the few minutes. So then a lot of the investigation was done in this area. And it can also explain the mechanisms of the aura during a migraine, because we can see the shifting of the cortical spreading, the depression started from the back of the cortex and gradually go and cover the cortex, and also it caused the oligemia and decreased the neuronal depolarization. And in this area, it could cause the hyperemia and increase of the neuronal depolarization, where can explain some kind of the overlapping between the epilepsy and migraine. Actually, this kind of the depolarization and depression usually occur in a patient with some the ion channel mutation, like a calcium or sodium channel mutation. In this group, it could happen more often. And then the depolarization wave initiation started from the overaction of the MPA and NMDA receptors. And then the influx of the calcium and sodium ions into neurons, they caused the outflux of the potassium ions into extracellular space, and it can cause the glial cell activation and energy depletion. And this kind of the propagation of the cortical spreading depression could cause the ion homeostasis breakdown and accumulation of the extracellular potassium and glutamate, and it can cause the wave of the depolarization propagates very slowly, about the 3-5 millimeter per minute, and it also caused by itself the inflammation mediator release like CGRP, substance P, prostaglandins, and this kind of the vasodilatation of meningeal vessels could cause activation of the trigeminal nociceptive the mechanism and cause the headache after all. Now we are living in a genetics area, and a lot of investigation has been done in this learning of the genetics of the migraine, and some of them perfectly known that cause familial hemiplegic migraine and can trigger a different type of the mechanisms, mostly the glutamatergic and the inhibitory interneuron mechanism that cause the migraine. And if we look at the landscape of the past and near future of genetic research in this field, we can see that the last 5 years, a lot of new genetic variants were discovered. But more than 180 known variants belong to several complex of the network, and that can cause the pro-migraine molecular abnormalities. And in the context of the migraine, where it's some kind of the complex disorder, where not just the genetic factors and also the environment can cause and can affect to the patients, we need to know perfectly well that the understanding of the polygenic risk scores. What is this? It's a number that estimates a person's genetic risk for developing a particular disease, because sometimes the combined effect of the genetic variants and also family history can cause that we can see some kind of the activation or the clinical picture of some kind of the genetic variation. Because multiple genetic variants, especially in the context of epilepsy, migraine, diabetes, are influenced by many small genetic variation. And these variations are called single nucleotide polymorphism. And the Genome-Wide Association study, this is the large study that compared the genomes of people with and without the disease, and to find the this kind of the single nucleotide polymorphism associated with this condition. And this scoring the risk for and weighting for each variant based how strongly it's linked to the disease. And then they calculated the score. And this kind of the very interesting and large-scale research was done in Finland, and they learned the common variant burden contributions of the familial aggregation of the 1,589 families by doing the whole exome sequence to whole exome sequencing, and they found out that in a group of the patient different, and they look at the different subtype of the migraine, hemiplegic migraine, migraine with typical aura, without aura, with any migraine and no migraine, and you can see the large difference of the polygenic risk factor burden observed in the different type of the migraine, especially the migraine with typical aura and hemiplegic migraine. And regarding the investigation, whether it can, I mean that when this overlapping very often, migraine and epilepsy, and can it, for example, can migraine had the bad impact has the bad impact on epilepsy, and epilepsy controlled by itself? Another very good study from Veleoğlu that was done in 2005, where they look at the 59 patients with the epilepsy and compare their findings with 56 patients without with migraine and the without migraine, and on the prognosis, and they follow up the patients about 10 years and make the Kaplan-Meier analysis for epilepsy patients with and without migraine. And you can see that the group of the patient and look at the seizure-free period of this patient, and you can see that the patient with migraine group, epilepsy migraine versus just the epilepsy group during these years have the shorter seizure-free period than the patient group with only with epilepsy without migraine. So also the rise the knowledge and the information regarding it could also they can affect the bad effect on the seizure control by itself. So during this talk, I would like to overall make a review the existent literature regarding the overlapping migraine and epilepsy, and try to summarize the known pathophysiological mechanisms that share these two chronicle and paroxysmal neurological condition. Thank you very much for your attention.
Dear Ulviye, thank you so much for very interesting clinical cases and presentation. And we go and we have some questions. So one of the questions from our colleague Sabina, she's asking about case 2. You said this child had no seizures for 4 years, but what about headaches?
This is very nice question. But unfortunately, I don't have information regarding his headache now, because as you know, and it also was done in some research where the patient with the seizures, usually the headache is just overmissed in this context, because the seizure, the increase, the more how to say it, stress regarding this condition, that the headache, and that's why they regularly reported regarding the seizure frequency, whether the patient has seizure or not, but not about the headache. But it's a nice question. I will ask.
Thank you so much. So our colleagues, do you have any question?
Maybe a question from my side, Serkan. Thank you, Dr. Ulya, for the presentation of these interesting cases and for this comprehensive talk. I wonder, in your clinical practice, when do you perform genetic testing in these patients?
Usually we do not perform the genetic testing in a regular base to patient with migraine. But of course, the patient with some kind of the neurological plus symptoms, and for example, some kind of the epilepsy, for example, comorbidity with epilepsy or familial hemiplegic migraine and such kind of the other neurological presentation that can cause that can can be genetic, and we can find some kind the symptoms of some kind of the known genetic disease. In this case, of course, we can look at the genetic investigation, but not in a regular base.
Oh, okay, I see. I just wanted to, yeah, okay, thank you.
Any question?
I think we have another question from the audience. Is the EEG necessary in every child who describes aura, even if there's no clinical seizure? When is it required?
I think yes, because it's really sometimes difficult to differentiate the aura from the focal onset seizure. And in such cases, like the cases that I presented and also Sura presented, you can see some kind of the hard to differentiate whether it's really my aura due to migraine or due to epilepsy. And in these settings, EEG is not so expensive investigation, and we can do it. But of course, we should be very careful with the evaluation of the EEG results, because we can see, especially in a children population, during the sleep, some kind of the EEG findings, central spikes, and so on. So we should be careful and also to try to correlate aura, the feeling, with the EEG findings, whether it's explained or not.
Thank you so much. Any question more? Okay, so I have one question, Ulviye. So my question is, in our daily practice, we can see a lot of patients that have been taken EEG, especially more elder patients. And my question is, when we should precisely refer our patients to EEG? When we see patients with migraine or headache?
Okay. If you have the patient with a headache that you can classify it easily, whether it's migraine or the other primary headache, and you don't have any other questions and you have any suspicions to epilepsy or other paroxysmal event, especially epilepsy in context of the EEG, there is no need to do EEG for diagnosis in these patients. But of course, the cases with aura, whether you can also face to the focal onset seizures, or for example, some kind of the headache, but before the headache, the period of the confusional state, especially in older patient. And there is no, for example, the witnesses that can describe clearly what happened with the patients. And in this case, of course, for example, if there is a late onset for the primary headache, or some kind of the questions that also not explained perfectly by the context of some kind of the headache syndrome. In this case, EEG could be effective for the diagnosing.
Yeah, thank you so much. I totally agree with you. And Dova, do you have any question?
I think we don't have any other questions. Esme?
Oh, let me summarize.
Would you like to make a summary?
Yeah, great pleasure. And first of all, I would like to thank again our colleagues from Azerbaijan for these interesting cases and for their comprehensive talks. Let me summarize some of the key messages of this meeting, this webinar. The comorbidity of migraine with epilepsy is very frequent, and both of these conditions have overlapping symptoms and shared pathophysiological mechanisms. In pediatric population with epilepsy have also an increased risk of migraine similar to adult population. And therefore, EEG should be performed to differentiate these two conditions, especially migraine with aura and epileptic seizures, such as seizures seen in occipital lobe epilepsy. And this is even more important in the pediatric population, but not every headache requires EEG. This may be confusing and lead to misdiagnosis of epilepsy and unnecessary use of anti-epileptic drugs. And for this reason, detailed evaluation of the headache and of the symptoms are crucial, and a detailed clinical evaluations will provide us important clues as emphasized by our colleagues. Thank you. And now I want to give my word to my colleague and my dear friend, Serkan Amerkuliev, for closing remarks. Please, Serkan.
Yeah. Thank you so much for inviting to this webinar. I think it was very interesting and very useful. And we have learned a lot of things today, and it can be helpful in our daily practice. And we look forward to see you again.
Yes, of course. In the next webinars, online meetings, or in the on-site meetings. Our pleasure to collaborate in this field with you. Thanks again.
Thank you so much.
Yeah. Thank you.
Thank
Hope
you.
to see you next time.
See you
Bye.
next time, and good evening to our
Audience.
audience. Yes.